Hello and welcome to this online lecture on asthma hosted by Paramedical Services. This lecture will include an overview of the anatomy of the airway, the characteristics of asthma, the different triggers or causes of asthma attacks, how to assess the patient and recognize the signs and symptoms of a mild, moderate and severe asthma attack, and then how to treat the patient experiencing an asthma attack in the pre-hospital setting, and this is directed at the level of the EMT. Quickly reviewing the basics of the anatomy of the airway is the airway is divided into the upper airways and the lower airways. The upper airways comprise of the nose, nasal cavity and the nasopharynx, the mouth, the oral cavity and the oropharynx, and then just below that we have the epiglottis covering over the larynx where the vocal cords are housed, and it's the division point between the upper and the lower airways. Moving on down then into the lower airways is the trachea, protected by those cartilage rings. The trachea bifurcates into the left and the right main bronchus, or the primary bronchi. This then divides into smaller branches in the left and the right hand lungs, which are called the secondary bronchi, which then further divide into the smallest airways, which are the bronchioles attached onto our alveoli. And we have a zoomed in picture over here of what those alveoli and alveolar sacs look like attached onto those little bronchioles. It's important to note here that from the upper airway all the way down to the bronchioles in the most distal portion of the airways, that no gaseous exchange occurs through these passageways in the respiratory system. So this space is called dead space because there's no exchange of oxygen and carbon dioxide between the respiratory and the cardiovascular system. The only site in the respiratory system in which gaseous exchange occurs is all the way right down in the alveolar sacs, which are richly supplied with a network of blood vessels in which gaseous exchange occurs and oxygenation of our cardiovascular system takes place. Bringing your attention to the picture on the right hand side of the screen, we have an illustration of a cross-section through the airway. So this can either be in a bronchi or a bronchioles. These pipes and tubes are regulated in their size by muscles, as we can see here, that are within the walls of the airway. This controls how much air flows all the way down to our alveoli, and they can be either increased or decreased in size depending on whether the muscles constrict or relaxed. So if the muscles constrict, the airway gets smaller and smaller, and if those muscles cause dilation, then the airway widens and increases in size. And it's also important to note here that we have a thin layer of mucus cells running along the whole of the inside of our airways, from the top of our nose all the way down to the very end point of these bronchioles where the alveoli attach. These mucus cells are incredibly important for humidifying air that we breathe in, and also for trapping any foreign bodies in the mucus, and these get pushed up through the respiratory tract, which can then get coughed out. These are two very important anatomical characteristics of the airway that we need to understand so we can also understand the process of the acute asthma attack. Asthma is a chronic inflammatory condition of the bronchi and the bronchioles, which is characterized by acute asthma attacks. These attacks are reversible with medications, and we'll discuss a bit more about these later on in the presentation and describe how they work. Asthma is a very common condition. In fact, 1 in every 9 Australians has asthma. And although asthma attacks can range from mild, moderate, and severe, it is considered a life-threatening condition. In 2014, there were 419 deaths attributed to asthma, which unfortunately many of these could have actually been avoidable with the correct treatment and the correct management. There are three distinct processes that produce airway obstruction, which leads to an acute asthma attack. The first is bronchospasm. The bronchospasm is produced by the muscles in and around the bronchi and the bronchiole. When those muscles are activated to contract, they constrict around the airways and cause a narrowing of the patient's airways that we can see on the top portion of the picture over here. The second process that happens is the swelling. Now, because asthma is an inflammatory condition, wherever there's inflammation, there's usually swelling of the tissue because of lots of fluid buildup there, which is also called edema. And we can also see in this diagram over here, the tissue has become quite thick and swollen. Then the third characteristic of the asthma attack is the formation of a mucus plug. When an irritant overstimulates these mucous membranes, they produce excessive amounts of mucus, and what can happen is that mucus becomes so thick and congested in an area that it can form a plug in severe conditions. And what this will result in, instead of having a nice clear airway or windpipe for air to get down to our alveoli, the airway in the asthma attack becomes narrowed and constricted, and also can cause an actual obstruction in the airflow down to the alveolar sacs. And unfortunately, a lot of air gets trapped in those air sacs and cannot escape properly. So we get these hyperinflated alveoli where little bits of air can get in, but air is generally trapped inside those spaces and cannot get out. This acute asthma attack, often referred to as an acute bronchospasm, can occur in the asthmatic patient, but can also occur in the non-asthmatic patient. In the non-asthmatic patient, this can be a result of a lung infection, toxic fume inhalations, and smoke inhalations. But in the asthmatic patient, there are many different types of irritants or triggers that can cause an asthma attack. These different triggers of an asthma attack or an acute bronchospasm can include contact with pets or different types of animals, exercise, pollens, bugs such as dust mites, chemical fumes, extreme changes in the weather, particularly in the winter months where we have those extreme decreases in temperatures, different fungi spores. So if there's any mold in the house, this will be a really big trigger for the asthmatic patient. Dust, smoking, isn't smoking cigarettes, but that can also include smoke inhalation from house fires and pollution. Strong odors can also trigger asthma attacks, and that can include things such as paint fumes, and then different types of emotions such as anger and stress can also trigger off an asthma attack. 90% of all childhood bronchospasms is a result of an allergen. And most childhood asthma that's brought on by exercise does decrease as the child grows older, and some patients have reported that they are no longer experiencing any asthma attacks or bronchospasms in adulthood. The signs and symptoms of an asthma attack can include spasmodic coughing, which is unproductive in character. That means that the patient is not coughing up any mucus or phlegm. And this occurs because all the mucus buildup is right down in the lower portions of the airway. Wheezing is the characteristic lung sound of asthma. Wheezing can be heard audibly sometimes when you come into close proximity to the patient, but the majority of the time it needs you to listen to the patient's chest using your stethoscope. Wheezing can be inspiratory, so you hear a wheezing sound when the patient breathes in, and wheezing can also be expiratory. Expiratory is the most common because when the mucus plug forms, it's not so much that somebody has trouble breathing in, it's more so they have trouble exhaling or breathing out because of that air trapping inside the chest. So you most often heard expiratory wheezing, but you can also hear inspiratory wheezing. In very severe cases, we can get what's called a silent chest. The silent chest means that when you go and auscultate with your stethoscope, you're not going to hear any wheezing, or it's going to be very, very fine and very minimal. And people can mistake this as the patient actually starting to improve, or that their wheezing isn't really that bad, but actually can mean the complete opposite. This can indicate that the patient's airways have narrowed so much and the mucus plug has occluded or blocked that lower airway to such a degree that air is not even moving in and out of the alveoli. So we get this silent chest. And we have a little clip to play for you now so you can hear what that wheezing sound may sound like on a patient. In that portion of the clip, which you can listen to again if you'd like to, there's the shorter inspiratory wheeze that you hear, and then a longer expiratory wheeze. Wheezing is produced, as we've mentioned already, by this bronchospasm, the swelling in the airway, and the mucus production. Anytime that you hear a wheezing sound, it means that there's an obstruction within the airway. And in asthma patients, this is all occurring in the lower portions of the airway. Patients, because of all these obstructions, feel like they have this tightness or squeezing inside their chest, which it makes breathing quite difficult. So often complain of dyspnea, and you might have a fast breathing rate or fast respiratory rate, medical term being tachypnea. You may note that there's also quite significant changes in the speech pattern. Speech is produced when air rushes out of the lungs past the vocal cords. So if we notice that a patient struggles to get a full sentence out, or they can only speak in words between each breath that they take, it means that they are having major air trapping and major difficulty in their breathing. We may start to notice signs and symptoms such as cyanosis, especially when things are progressing to the moderate and severe cases. Cyanosis is a clear sign that we don't have enough oxygen inside the bloodstream. So we see the central cyanosis, which is that blue discoloration around the nose and the mouth. And you can also witness peripheral cyanosis all the way down at the fingertips. As you can imagine, these patients are going to be quite anxious and restless because they're struggling to breathe and they feel like they can't get enough air or oxygen into their system. Posturing is quite a significant sign as well to understand how severe the attack is. When observing a patient's posture, patients will naturally assume the tripod position if they're having difficulty in breathing. This position entails somebody either sitting upwards and leaning forwards and bracing themselves on their legs or onto an object such as a bed or a desk, as this naturally increases their tidal volume and makes breathing easier. And generally, a patient who's having a moderate to severe attack will not be able to sit down in a chair and assume that semi-reclined position, or they won't be able to lay down either because it's just too difficult to breathe in those positions. So just take note when you first assess the patient what position they're in, as this can also give you a good indication of their degree in difficulty in breathing. In response to all of these changes that are happening inside the body, not having enough oxygen in it and increasing the respiratory rate, the heart rate also increases to try and compensate for this hypoxia or lack of oxygen inside the body. So we'll often see an elevated heart rate, or what's called a tachycardia. The patient can also start to become diaphoretic or sweaty because of the stimulation of the sympathetic nervous system, of that fight or flight reaction. And we may start to also note the use of accessory muscles when the asthma attack becomes moderate to severe. The normal muscles of respiration include the diaphragm and the intercostal muscles. Accessory muscles include the trapezius muscles on the shoulder, the scalene muscles running down from the neck to the chest, and the sternocleidoid mastoid muscles in the neck over here. These are quite easy to see on a patient when they're being activated because you can see major depressions in the neck running parallel and in comparison to these big muscles that are activated in the neck that you can see quite well. The pectoral muscles, however, are very difficult to see being engaged when somebody is having difficulty in breathing, but we may also start to notice things like intercostal muscle retractions or abdominal muscle engaging in respirations. When the abdominal muscles are engaging in respirations, if we have a look at the chest to the abdomen, we can see that the muscles start to contract and it causes the seesaw movement between the chest and the abdo. So the chest will move out and the abdomen would move in, and then vice versa during breathing. When patients get to the stage when they're making use of accessory muscles, because they're engaging so many other muscles in their breathing and there's so much work and difficulty in breathing properly, that they start to use up quite a lot of their glucose or sugar stores within the body. So also be aware that somebody, particularly if they are a diabetic patient, may be getting dangerously low sugar levels because of this increased workload during breathing. The signs and symptoms that we have spoken about help us to differentiate whether somebody's having a mild, moderate, or severe asthma attack, or if it's now where it's a life-threatening condition and respiratory arrest is imminent. In the category of breathlessness, the patient starting off with a mild condition only gets breathless after walking or going up a flight of stairs, and this progressively worsens through each category. The patient's position, in the mild case, they may be able to tolerate laying down or sitting back comfortably in a chair in the reclined position, but as the condition worsens, the patient slowly has to be more seated upright or in that tripod position, and if respiratory arrest is imminent, they may actually be unconscious at this stage, laying supine. Speech I'll come back to in a minute because I want to highlight a few things there. Their alertness or level of consciousness may just be slightly agitated in the mild condition, but progressing to a decreased level of consciousness in the more severe cases. Sweating may not be present in the mild case unless somebody has been engaged in physical activity, but slowly increases to being profusely sweaty in the severe case. Respiratory rate increases through these categories, and use of accessory muscles also increases through these categories. Under the category of wheezing is in the mild to the moderate. We may only be hearing wheezing during exhalation or expiratory wheezing, but in the more severe cases, this could be loud inspiratory and expiratory wheezing to a silent chest. Going back to the speech, and the reason I wanted to discuss this last is this is one of the easiest and possibly could be one of the most significant ways of differentiating between mild, moderate, severe, and life-threatening, is because, as we've mentioned already, in order to speak, somebody needs to be exhaling appropriately, pushing air past the vocal cords. And because asthma is more so a problem of breathing out, this is one of the best indications to whether somebody is breathing out appropriately and gives us a really good understanding of their respiratory capacity. So if somebody is able to speak in full sentences between taking each breath, it's really a mild reaction because we've still got good expiration. However, if somebody can only speak in phrases and then has to take a breath within the sentence, then this falls under a moderate capacity. If somebody can only speak one or two words and then has to take a breath, this is severe. And if the patient is no longer communicating with us and is unable to speak, this is the life-threatening respiratory arrest is imminent. This is one of the easiest ways and possibly one of the most significant ways of determining about which category of the asthma attack the patient falls under. When conducting our assessment on the asthmatic patient, we'll start off doing our DRS ABCD. So assess for danger, check the patient's responsiveness. You can use the AVPU score or the GCS. Send for help. Assess the airway. Remember, if somebody is speaking to us, their airway is open and clear. But if somebody is unconscious and not responding, we need to manually open the airway and look inside. Assess for coloration, because that can give us a good indication of their blood oxygen levels. And also assess for things such as swelling or bleeding inside the airway. When checking for breathing, check for the rate. Is it fast or slow? The rhythm, is it regularly breathing in and out every few seconds? And the depth, we want to see good rise and fall of the chest. This is just a quick check to see what's happening with this patient. If we're suspecting asthma or a respiratory condition at this stage, we need to auscultate. While we're assessing the patient's breathing, we can also do a quick circulation check, so feeling for a patient's pulse. And we're not counting the rate at this stage, but we just want to feel, does it feel fast? Does it feel slow? With the rhythm, does it feel regular? And how strong is this heartbeat? Then assessing the patient's vital signs, assess the heart rate, respiratory rate, blood pressure, skin color and temperature, and the quality of the skin as well. So is it dry or is it sweaty and diaphoretic? You can also check the blood oxygen saturations level using a SATS probe. And the vital signs can be re-evaluated every 5 to 15 minutes depending on the severity of the patient. During your secondary assessment, do a thorough chest examination, particularly looking for things like accessory muscle use during ventilation, jugular vein distension, having a good listen again to the chest and the apexes and bases, listening for wheezing or any adventitious sounds. Also looking at the shape of the chest. Does it look normal or does it look inflated into what we call a barrel chest? And also assess the abdomen for any of that paradoxical moving. During your history, you can ask about allergies, medications that the patient is currently taking. With asthma patients, they can take preventers, which they might take once a week or could take every single day to help prevent asthma attacks from happening. But they also have their relievers, which are the puffers or the asthma medication that they use during an asthma attack. They also could be on a multitude of other medications depending on their past medical history. So just because somebody has divulged to us that they are an asthmatic patient, don't forget to ask them about any other medical conditions that they may have. Ask about the last oral intake, so whether the patient has had anything to eat or drink today, particularly in those patients who had labored breathing for a long period of time because we're concerned about their blood sugar levels. And ask about the events leading up to the asthma attack. Specific questions to ask an asthmatic can include, have you ever been sent to hospital during an asthma attack? And have you ever become unconscious during an asthma attack? These two questions can help us understand at what risk somebody is of going into that severe or life-threatening category, and can just give us a bit of a heads up when a patient isn't maybe responding very well to their reliever medication, to whether or not we should be calling for backup quickly or loading the patient and transporting to hospital quite rapidly. After assessing the patient, then position the patient in the most comfortable position for them. So if they're conscious, we want them seated and upright so that we help to expand that thoracic cavity and hopefully make breathing easier for them. But if the patient is unconscious and breathing adequately, we can have them in the lateral or the recovery position. However, if they're not breathing adequately, so they're hypoventilating, then we can have them in the supine position, and that's where we'll provide IPPV and ventilate them using a bag valve mask. With regards to oxygen therapy, if the patient is breathing adequately, we can use oxygen therapy mask. If the patient is hypoventilating and they have a decreased tidal volume or a decreased respiratory rate, we will then have to assist their ventilations using IPPV with the bag valve mask. So for medications and interventions, we can administer or assist in administering the patient's own bronchodilator or reliever, which is called Ventolin, and we'll do this using the 4x4x4 method, which I'll show you on the next slide. And then we need to monitor the patient's condition, so constantly monitoring their level of consciousness and their vital signs, looking for any improvement or deterioration of their condition. If we're ever with a patient who is in a severe or life-threatening stage of asthma, we can also provide what's called lateral chest thrusts. We use these to assist in exhalation for the patient. So please don't try and attempt to do these on anyone until you've been practically trained in this skill, because if you do it incorrectly, you can actually cause damage to the lung tissue. You will get ample time though to practice this skill and master it in your face-to-face training. When administering the asthma puffer with Ventolin in it, it can be quite a difficult thing for a patient to coordinate, especially when they become anxious and they're panicking and they have a difficulty in breathing and increased respirations in adults, but even more so in children. It can be quite hard for them to try and coordinate pressing in the inhaler device and at the same time as that medication is ejected from the device to actually inhale it correctly all the way down into the most distal portion of their lungs. So spacer devices were created to hold the medication in a chamber so that less coordination needed to take place to inhale it correctly. A spacer device has a one-way valve on it and a mouthpiece, and the inhaler device attaches into the back of it. This is a closed chamber, so you can press one pump of the salbutamol into the spacer device and the medication is held in here. This gives the patient time to exhale as much as they can. They then put their lips around the spacing device and take a nice deep inhalation and hopefully breathe in all that salbutamol right down to the lower airways where it needs to go. They've done many studies on different devices to use during an asthma attack, and the spacer device has been the most effective in getting the medication right down to the position it needs to be in. So I'm going to explain the 4x4x4 method. This has been established by the Asthma Foundation as a method in which to administer the medication during asthma safely. So firstly, we'll have a look at how to administer with a spacer device. One puff of the medication is to be administered into the spacer, and then the patient needs to breathe in and out of the spacer 4 times. This needs to be repeated 4 times, and then wait for 4 minutes and reassess the patient. After waiting for 4 minutes to see if that medication has effect, if the patient's condition has not changed, just repeat this process again. And now we'll talk through how to do the 4x4x4 method without a spacer device. So if somebody is just using the asthma puffer or reliever, then we administer 1 puff, ask the patient to hold their breath for 4 seconds, repeat the process 4 times, and wait for 4 minutes and reassess. We will have time in your face-to-face sessions to go through these principles again and actually be able to put them into practice, which will help you to remember the methods. This concludes the online presentation on asthma. If you have any questions or clarifications, please don't hesitate to contact paramedical services.